Hello students, my name is Moon. This is He200, the EMT class at Queensborough Community College, and this is Chapter 35, Emergencies for Patients with Special Challenges. The majority of our calls will be for ordinary adults. They were having an ordinary life and then suddenly they are complaining of a medical emergency. Sometimes you will have children, but you've already been trained how to deal with that. Now, once in a while, however, you will have a patient with a special challenge. They have an ongoing or chronic condition, but that's not the chief complaint. Something else caused them to call 911. Meanwhile, they have this other thing going on in their lives. But that's something that's going to affect the way you treat them, the way you assess them, the way you take care of them. As always, you always stay professional, compassionate, do your job, and everything will be fine. When possible, establish rapport. I think that's how you pronounce it. It's a fancy way of saying get on the good side of the patient as well as get on the good side of the family, and that's where the professionalism and compassion comes in. By the way, if this is a chronic condition that the patient is dealing with, then they've dealt with EMTs before, and they've seen good EMTs and bad EMTs. So the initial way they treat you will probably be along the lines of they'll give you the benefit of the doubt, but they know the business. They know what EMTs do. So don't try to pull any funny stuff. Don't try to gaslight them or blow smoke around them. They've seen it all before. So instead, just do your job, be professional, show compassion. It's always a good idea to introduce yourself no matter what the patient is, because if you're a stranger in somebody's house, that is just the right thing to do. Introduce yourself, introduce your teammates, and then also while you're there, they call 911, but it's a good idea to recap, move slowly and deliberately, no surprises, and when possible, as best as you can, stay at eye level. So sometimes, if they're lying on the ground or on the bed, you don't want to be exactly there, but don't be standing there with an air of authority and dominance, because it's just not going to work. It's going to backfire on you, and you're going to regret it. So humility is always a good starting point. Many things can cause a disability. Here's a couple of them that we'll talk about, but this is by no means this entire lecture. In fact, this entire semester has only been about common or possible or the most possible experiences, but there's no implication that these are the only kinds of patients you may have. Disability is any kind of chronic situation where the patient is unable to perform one or more of basic functions that other people enjoy as they go about their lives. And so the previous slide talked about Down syndrome and cerebral palsy, and here's a few more. Some people do survive their stroke experience, but then they don't get to the hospital in time, so they were unable to be saved out of some of their symptoms, and now they're stuck with it. Many of these patients do live independently, and so they do it with pride. So to take that away from them, to force them into certain decisions or maneuvers may be just disrespectful. That's where the professionalism and compassion comes in. Work with them, not against them. A trend or a philosophy of medicine today is not to keep the patient in the hospital. For starters, that is like the most expensive thing to do. Of all of the treatment modalities available, staying in the hospital is the most expensive, and with insurance not being unwilling to cover more and more of these treatments, the poor patient will be stuck with the bill. So instead, the idea is to stabilize them in the hospital. The purpose of the hospital is only for stabilization and treatment. And then as soon as the patient can be transported home safely and kept at home safely, then send them home as soon as possible, as soon as safe and reasonable too. That reduces cost. Also, the patient is surrounded by a familiar environment that creates less stress, and that actually leads to faster recovery. The opposite is true. Being stuck in a strange hospital with strange smells, sharing a room with a strange person who is having their own problems, and their own family members are walking in and out. You have strange staff coming in and out, poking them at all hours of the day. And then the channels on the TV are not even anything worth looking at. And so that is a very stressful experience. It can actually slow down healing, slow down recovery. So get them out of the hospital as long as it's safe to do so and it makes medical sense. But that's where you come in, right? You're doing the transport home, or you're doing the transport back to the hospital because something may have gone wrong. One downside, however, of staying home is that whoever's there at home to take care of the patient may not be fully trained. At least in a hospital, you have LPNs and RNs and physician assistants, specialists and consultants, all of them available within a moment's notice. Some of the top level experts may take a few minutes, but anyway, whenever help is needed, it's not too far away. At home, however, the problem is that whoever is available to help with this patient may not be completely trained, may not have all of the information, may not have all of the equipment, and sometimes a family member just doesn't have the energy. They're living a full life, they have other family members, other dependents to take care of as well as themselves, and now they have to deal with this. The family member who is suffering from some kind of recent or chronic condition who is needing extra time. The stress level for the family member themselves is going through the roof. They're going to need support groups. They're going to need support services for themselves while they're taking care of their loved ones. So you, as an EMT, with the privilege of being allowed into their house through the closed doors, has a rare look at the environment that this patient, the original patient you're sent to, is living in. So keep your eyes open, be aware, and one of the things you want to look for is the mental state of the caretakers. Do they look exhausted, or do they look agitated, or do they look strained, stressed? Make a note of that. Okay. With disability, there's a physical disability and an intellectual disability. And it's not always the same. I know coming into healthcare for your very first time, for many of you have not had any kind of healthcare class in the past, and not had any kind of medical education in the past. So who knows what ideas you had from the general public and from your own casual experiences. But now, after only 4 months here in this EMT course, and then you graduate, you maybe take a month to pass the written exam, and then out you go into the streets on an ambulance, and then you run into somebody with all kinds of medical complications. So of course, nobody is expecting you to know everything on the first day, but that's where continuing medical education comes in. When you graduate from this course, you don't know everything, but hopefully you know all that you need in order to educate yourself ongoing, to learn. You are now ready to teach yourself, to do your own research, to read about the things that you tend to run into in your neighborhood, in your agencies. And so little by little, you are adding to your knowledge. until finally, many years later, you are the true, well-educated, well-knowledgeable, highly knowledgeable professional that everybody needs from you. So with an intellectual disability, it's separate from a physical disability, is that they have like a fully functioning body, except that their mind is not at the controls as well as you would expect like an adult or a child of that age. It can be because of a development, so they had difficulties growing into their roles, meeting their developmental milestones. It can be, or it's a kind of developmental disability is when they are unable to think. So their reasoning ability, their social interacting ability are impaired for one reason or another. The problem now is that if they are developmentally delayed development, so their mental ability, as it's at some level that's more appropriate for somebody much younger. The problem is that you could have like a child in an adult's body. The problem is that they have childish motivations and instincts, but they have the power of an adult's body. And so we call that acting out when children do it, but so when this patient does it, they're also acting out. Sometimes they just don't understand. And one key to addressing this kind of a situation is, first of all, don't take it personally. They're not doing it because they're disrespecting you. They're not doing it because they hate you. They may say things that sound like exactly that, but they're just saying things because that's what they learned to say. It's not because they made some kind of actual judgment call on you as a person, your value in life. They are just responding to your uniform and the system it represents, and not the system, the medical system that you understand, but the medical system that they have experienced from their point of view, from their past. So don't take it personally, stay professional, and just work in the best interest of, first of all, your safety, of course, but then after that, the patient's best interest. When you are addressing a situation that is completely completely unfamiliar, you only heard about it in textbooks, and here you are actually dealing with a real life situation of it, then a great resource is the patient's own family members and other bystanders who are with the patient. So use them as a resource. Not only should you get on their good side, but then you can have them help the patient. They know what the right thing to do is. They know which buttons to push. They know which dials to turn. So turn to them for answers. Don't have them lift the patient, though. Lifting the patient is your job. Don't help them use a BVM or hold manual stabilization of the head. That's your job. All the things you train to do for anybody else is your job. But specifics of taking care of this patient's particular medical situation, that's where they can help you. So, by now, up to now, in the previous slides, probably one of the intellectual disabilities that is popping into your head as I was describing it was autism. So here it is. 1 in 68 children. That's a lot, because we have millions of children here in New York City, and so we're talking about thousands and thousands of children born with autism, even in our local area. So there's a fair chance that you'll eventually run into one of them. Autism, by the way, is a spectrum. If you've seen one, you've only seen one. It doesn't mean you've seen them all. And there's actually a huge range of levels of functioning in autism. Some can actually function very well in society and can even succeed, make a lot of money, be popular and successful and famous. and nobody realized that they were a high functioning autism. In fact, that used to be a completely separate disease called Asperger syndrome, although that was in the DSM-4. In the current version of the DSM, the Diagnostic Statistic Manual for mental disorders, the DSM-5, it's all been merged together into high functioning autism. So that's the high range, but it can go all the way down to needing constant supervision, unable to function in society, unable to even be left alone for any amount of time safely. They have to always be kept an eye on so they don't hurt themselves. Many people with autism look normal on the outside, meaning that if they just sat there, nobody would have guessed that they had some kind of medical situation going on until it's time to interact with them, and that is actually the problem with autism. Whoops. Okay. The problem with autism is that it's a deficit in social communication. Social cues, social interactions, that is the problem. Something is wrong with what's going on in the child's head, that levels of social interaction that you would expect of somebody that age is just not there. And it actually that alone by itself can really impact somebody's well-being in society. When do children get first noticed with autism? At 1-year-old? No, because there's no social interaction at 1-year-old. Yeah, 1-year-olds smile at faces, but you can show a piece of paper with 2 dots and a curve, and the 1-year-old will smile at that. They just smile at faces, and it's a great evolutionary adaptation, by the way, to make everybody like you. So when do you get the first clue that this child has autism? Well, when do you get the first clue that they are not interacting socially at the milestone they're supposed to be? Or when do they first interact socially at all? About 2 years. And because around the 2nd year of life is when the child gets the ability to say no. Letters N-O, no. It's not when they first learn how to say yes, because any robot can say yes. You write a program, and then you make it do what you tell it to do. It says, yes, I'll do it. You take a baby and you make it do things, and it just does it. But when the child turns around and says, no, I will not, I know what you want me to do, I'm not going to do it, now the child is expressing their own unique identity, their own unique personality. The twos, when they say no, is famous for being called the terrible twos, and that is actually when children are able to finally interact with you and say, no, I'm not going to do it. But then, because this child has autism, they are unable to do that in the ways that the parents expect. So seeing that their child is not acting in a usual way that they've been taught to expect, or they've seen it with other children, they take it to him or her to a pediatrician, and then the pediatrician does some tests and then comes up with a devastating diagnosis. I'm sorry, but I think your child has autism. So the parents just had their lives destroyed. All of these hopes and dreams they had for their child and their family come crashing down as they are faced with this devastating diagnosis. So what do? Like any good parent would do, they go onto the internet and start Googling, start searching for it. They learn all about the disease as much as what's out there on the internet. And then another thing that people do is look for somebody to blame. Look for a reason to blame. Like, why did it happen to our baby? And then inevitably, they will run across the first of many articles, social media influencers, videos, claiming that vaccines cause autism. And these parents with no medical background, they haven't even taken chemistry in high school. They didn't even take biology. They have no understanding of how these things work. They just read article after article. They go down this rabbit hole of anti-vaxxers, and they come out convinced that vaccines caused my child to have autism. And as far as they're concerned, it's completely logical. It's not logical. It's a fallacy. It's called correlation is not causation. Correlation is that between 6 months and 2 years of life, this child got a lot of vaccines, got a lot of needle sticks. It seems like every time they visited the pediatrician, they got stuck with a needle. And now they're told their child has autism. So they see A and then B, therefore A must cause B. But that is a fallacy. That's not true. After all, look at all the other kids who got vaccinated and did not get autism. Instead, what's actually going on is whatever did cause autism, and it's not confirmed yet. They still don't know what actually causes autism, but what the leading theories are that autism is a result of a developmental issue, and it could have been congenital, as in the child was born with it. So the child had autism from before, but nobody ever got a chance to notice it until the terrible twos, when they were supposed to start interacting socially, and now they don't. That was a tangent, obviously, but anytime the topic of autism comes up, it's almost guaranteed that somebody is going to mention vaccines. So to head that off, I feel like I have to say that here. Anyway, back on topic, what's going to happen with you when your patient has autism and a medical emergency? Well, so I said the most prevailing or the most noticeable attribute of autism is that they have difficulty with social interactions. So right there, that's going to be an issue as you try to interact with your patient. But then here, as a corollary or a follow-on from that basis, you have these other symptoms. They sometimes have abnormal sensory responses because they not only have difficulty interacting with other human beings in the usual way, but they also have difficulty interacting with other things, other sensory inputs in the usual way. Something as simple as the sensation of temperature or pain. They don't respond the same way with other people do. The sounds of laughing, humming, singing can cause them to have unusual or extreme reactions. The sensation of clothing on their skin and being added on or taken off. Even the sensation of you holding their hand. Maybe you just want to shake hands. Hi, it's nice to meet you, and you hold their hand, and they scream because it's not something they like. They feel pain. You did not cause the pain, but they feel pain when they have an unwanted and unusual sensory tactile sensation. So the summary of this slide is to say you wanted to keep everything calm and simple. Minimize stimulation. You may want to skip the blood pressure cuff here. Instead, you guesstimate that their circulation is okay because of their skin, pink, warm, and dry. You see that they're able to hold up their posture without signs of altered mental status. And as far as that's concerned, that's it. You see that their blood pressure is probably good enough. Of course, if somebody then If your supervisor then calls you later and say, why didn't you take a blood pressure, you can honestly say, patient refused. My patient had autism and they refused. Oh, can the patient refuse? Do they have the legal right to refuse treatment? Can they RMA? Of course not, because they're a child and because they have autism. However, the parents are allowed to refuse the blood pressure because the parents know what's going to happen if you try to get a blood pressure. And if the child really is screaming and acting out and creating a scene, then obviously your blood pressure number is going to be completely unreliable. So why even bother trying? But it's the parent who confirms and has the right to refuse the blood pressure. So I'm not happy with this choice of mnemonic, because as ENTs we already know what ABC stands for, and to say that there is an ABCS is kind of it's going to cause confusion for EMT students. But anyway, here it is, and you don't have to limit this to students, patients with autism. It's for anybody, any kind of situation. You always want to be aware. You want to keep things basic, keep things calm, and always focus on everybody's safety, especially your own. So anyway, another thing that people with autism seem to rely on is a pattern, a routine. They're all about the routine, and anything that disrupts that routine of what they're expecting out of life can also trigger a reaction. So, but then the problem is, what can be more disruptive than a medical emergency? So you're kind of stuck between a rock and a hard place. What do? Rely on the parents, rely on their next of kin to help you take care of this patient, and also give you ideas of what is the best way to get this patient to the hospital as safely and as quickly as possible. If your patient can talk, and not all of them can or want to have a conversation, but if your patient can and will have a minimal conversation with you, again, keep it simple, keep it basic. You're really there to make sure their airway is okay, their breathing is okay, their circulation is okay, and if their mental status is okay. And okay meaning at baseline, as in it's what it usually is. Let their caretaker tell you what their mental status usually is like, and if it's there today. As long as all of this is good, you know what, let's just transport and interact with this patient as minimally as possible. Calm creates calm, and so you staying calm will help the situation stay calm. Do not try to exert your authority. Do not try to dominate this patient. This patient does not understand authority. They don't understand domination. They just know that they are in mental pain and now they want to get out of it. That's all. The more you try to force somebody like this into compliance, the more they will not comply. They don't understand. Clear and controlled voice, not loud voice, but controlled voice. Lots and lots of empathy and compassion are very much your tools, and you'll find this useful. As long as it's not life-threatening, then you follow the patient's timeline, not your timeline. And if your supervisor, if your dispatcher is getting on your back saying, what's happening, where are you, why are you falling behind schedule, tell them, my patient has autism, they are acting out, I'm trying to not add to their stress. And as long as it's not a life-threatening emergency, obviously, right? Okay. If the patient is escalating, that means they are acting out. It means something has disrupted their routine in a way that is unacceptable. They don't understand what's going on. They're not doing this to disrespect you. They just want it to stop. Whatever it is distressing them, want it to stop. So work with a caretaker to figure out what it is and how best to handle the situation. Another common genetic condition in society, not every day, but you can eventually in your career end up with a patient with Down syndrome. Down syndrome is a genetic disease. Chromosome number 21 is, I better double check that. Down syndrome, chromosome 21, yes. Cleveland Clinic, okay, clevelandclinic.org, chromosome 21. So instead of having 2 of each, like we're supposed to have, these patients have 3 copies of chromosome 21, and it causes these symptoms like the face. The face is characteristic of Down syndrome. Its eyes are slanted and wide, and then the face is round. And in the old days, like before my time, this used to be called Mongoloidism, because 100 years ago they thought these children looked like Mongolians. I guess, but Koreans also have this wide set face too. I do, so maybe people would have confused me with Down syndrome. Flat occiput, which is not something you would notice because it's covered by hair until you do a physical exam, and severe intellectual impairment, mild to severe. Some are able to function in society. There is a person with Down syndrome who ended up being who was able to become a successful actor, but then he only portrayed characters who have Down syndrome. But people can live full independent lives with mild Down syndrome, but many of them need constant supervision to keep themselves safe and everybody else safe. Another symptom of Down syndrome is that some of them, so 15% of them, have a weakened C1, C2, which means that if they fell and a larger head, proportionally heavier, larger head, and the weaker C1, C2 means that their C-spine is extra at risk. So if you see this kind of a face and they are a victim of an accident, then you really need to make sure that you have manual stabilization of the head, and then get a C-collar on and do your other neurologic assessments. Another thing with trisomy X, trisomy means 3 copies of trisomy 21, is that the Down syndrome patients often have congenital heart defects. So circulation of the ABCs is definitely something you need to look at. And then don't be surprised if you may have to call for paramedics to get an EKG and do a further evaluation of their heart. You as an EMT should be aware of airway and breathing because their tongue is proportionally larger than larger than children of their age. So it has a increased chance of blocking the airway. For trauma patients, a jaw thrust maneuver absolutely is the preferred choice. An NPA may get you better results than an OPA because the NPA completely bypasses the tongue. Cerebral palsy, another disease unrelated to trisomy 21 Down syndrome. Cerebral palsy is usually or commonly a result of damage to the brain, either in utero, means before they were born, or at birth. What happens is, for some reason, oxygen doesn't reach the brain just before birth or at birth, and that causes anoxic brain injury. and then that ends up being permanent. Of course, trauma to the brain can also contribute too. Sometimes very, very, very early, they may get meningitis, which is an infection of the meninges, the membranes of the brain. But whatever the cause, the end result is that there is permanent brain damage to some part of the brain. Which parts of the brain? Completely random. It can, because remember, different parts of the brain are in charge of different parts of the body. But one common and classic symptom of cerebral palsy is the palsy. And palsy is a fancy word, a technical medical term for inability to control muscle coordination. The kid is in a wheelchair because he cannot control his leg muscles to stand by himself. But then I've seen many patients with cerebral palsy who are able to walk for themselves, but it's just not very coordinated. And while they're walking, their arms are often are out at random directions because, again, they have difficulty coordinating their muscles. I have queued up here a video of this gentleman who this is apparently his YouTube channel, and what he said was enlightening. So let me refresh this.
Cerebral palsy shows up differently in different people. Some people have mild cases, other people are nonverbal. I have spastic quadriplegia, which means I got all 4 limbs on my bingo card. To learn more about how you can help advocate for cerebral palsy research funding, visit www.gogreenforcp.org.
Your first impression might be that he is moving in an unusual way, and he's talking in an unusual way. His facial expression is unusual, position of his eyes is unusual. My impression is that this gentleman is thinking clearly. He's articulating clearly. He is completely, fully, mentally alert and oriented. This man is a smart person trapped in an uncoordinated body. It must be so frustrating to live life like that, to be fully aware of your medical condition and how everybody else is living their ordinary life, but you cannot. But then what do you do with this knowledge? Well, this gentleman went on and made a YouTube channel. This gentleman became an activist and is part of this awareness website and is a spokesperson for this advocacy group or activist group. So this gentleman has taken the cards he was dealt, the bingo card that he was dealt, and made the most out of his life. Many people with cerebral palsy are fully mentally alert and oriented. They are smart, and they have a well-functioning brain. Some don't, because again, it depends which part of the brain was damaged from that anoxic injury. Just because you met one doesn't mean you met them all. Some people with cerebral palsy have an intellectual disability, some don't. You cannot assume. Instead, take care of their airway, breathing, and circulation, and look to their caretakers for resources and clues of how to best get this patient to the hospital as safely and as quickly as possible. But then you have to be aware that, oh, I closed the window already. That video I showed was a fully grown man. So sometimes they have the power of a fully grown man, but they cannot control it. Their muscles are very strong, very, very strong, like a fully grown man or adult, but they have difficulty controlling it. Be aware of that. They cannot shift weights because shifting weights is a factor of muscle control. So they can often end up being very sore in the position they are in. So padding and pillows are appreciated. Never force the extremity into position. Again, they want to help you, they want to comply, but their body is not letting them. So forcing their body into a position may actually cause pain, can rip tendons and muscle. Look to their caretakers for assistance and advice. If they do take a walker or a wheelchair, try to bring it with them to the hospital. If they are chronic users of the 911 system, then they probably use the most convenient walker or chair that is consistent with EMS operations. Hopefully they will fit inside your ambulance. Many do. If it doesn't, then coordinate with the caretaker to bring it with them to the hospital. Anoxic brain injury sometimes causes leaves a brain that has epilepsy or seizure disorder. If your patient may seize unexpectedly, so you should always have suction available. But you should always have suction available no matter what the patient you have. Toe to head, you're going to learn this in the pediatric chapter for children, especially children, because especially if they don't understand what's going on, then getting up and around their face to begin with may be very threatening and destabilizing. But instead, if you start at the toe and work your way up to the head, then by the time you get to the head, they can finally internalize that you are not there to hurt them, you are not there as a threat, you are there to help, and they'll finally, so it's like they gradually get used to you being there. So finally you got to the head, and then they will comply. Sometimes what should have taken only like a minute ends up taking a while because of the special needs. And so maybe a few breaks in between to give this poor kid a break may help them rest and recover, and so that you can resume and everybody is better off that way. That was it for developmental and intellectual disabilities. What about some chronic medical conditions? As an EMT, you will definitely run into an obese patient. Have to transport an obese patient up and down the stairs on a stair chair, lift a patient from the floor to your stretcher, lift the stretcher from the street onto your ambulance. The most common career-ending injury for EMS is back injury. So always protect yourself, BSI, scene safety. Obesity is, well, you know what, these are just numbers. Obesity is what you see. You can tell the patient is obese just by looking at them. And obese this time meaning bariatric, meaning they are a threat to your back if you have to lift them. That is your primary concern as an EMT. After all, you want to go home safe so you can get up the next day and do it all over again. When in doubt, call for backup. Call for lift assist. At the very least, they can send a fire truck, and four big buff firefighters will come and help you pick things up and put things down, as well as carry them up and down the steps. Definition of obesity is BMI of 30/4. BMI is body mass index. I have a few things to say about the BMI, but that's outside the scope of the EMT program. So maybe I'll mention it when we meet together in person on Monday. Or you can ask me to cover that, tell you what I think. But anyway, that's the official criteria. Obesity results in multiple follow-on diseases, especially heart disease. Obesity results in high blood pressure, results in heart disease. It can result in kidney disease and liver disease, artery disease. Take care of yourself. People who are even more obese, like 40 or more, they have difficulty breathing if forced to be in supine position. So the position of comfort is very much something you want to consider in order to, well, reduce stress and anxiety for the patient. You want to have enough people helping you lift, not only for your own safety, but the patient's safety too, because after all, if you cannot lift the patient, then you may accidentally drop them if only you and your partner try to do a job that's really meant for 4 people. You may feel upset that you have to lift this heavy person, but don't forget that the patient themselves may be embarrassed. Okay, whatever, you may have some opinions about how people become obese, but the patient themselves is not happy with the situation. They are the subject of ridicule and hate for most of their lives. They have mental health, anxiety, depression issues stemming from their obesity. They've tried to do stuff, they've tried to fix it, but throughout, as a mix of environment and society, and of course personal decisions too, have all conspired against them, and now they're in this situation. So don't add to their humiliation. You're there as a patient advocate, not their judge and juror. Ask them for their help, ask them for their advice. What's the best way to get them onto your stretcher and get them into the hospital? Get them into the ambulance so you can get them to the hospital. Plan ahead is a great first step to doing things safely. Don't try to pull somebody up by an arm, absolutely not on their leg, but don't try to pull him into sitting position with their one arm, because the body just does not handle that kind of weight the same way that an ordinary weighted person would be, a BMI of 25 or lower. So you may actually break something if you try to pull a obese person up with one of their arms. Instead, plan ahead, work with your partner. That is, if you want them in the sitting position. Coordinate, communicate all moves, and that's for any kind of lift. It's not just for obese patients, but any kind of lift. If at any point you feel the control of the situation slipping, then stop. Just simply stop. Come down to a rest position. What rest position? You should plan ahead for your rest positions, your intermediary steps. And as always, look for pinch points or pressure points on the equipment, because you don't want to cause DVT, deep vein thrombosis, on the transport. Okay, some patients you are justified in calling for lift assist, and sometimes then they will come with a bariatric ambulance. There's an entire ambulance designed to take extra large, extra heavy patients. See the ramp here, and see the extra handholds. It's not just the front and back, but the side handrails slide out too, so that and also the structural strength of the stretcher, this bariatric stretcher, can handle even heavier weights. I forgot how much, actually. Well, let's look it up. Bariatric stretcher. What is the weight limit for a medical stretcher? Who said this? Hillrom.com. What are they, a seller? Maximum weight limit 700 pounds. Weight limit for bariatric equipment. Oselco.com. Is that an equipment seller? 250 pound is not a lot, because that's the limit of the regular EMT. If you are required to lift 125 pounds per person, that's 250 for the two of you. What? Bariatric stretcher weight limit. Telchlem.com, stretcher maker, 750 weight capacity. So something like that. Okay. So plan ahead. As you're waiting for the bariatric ambulance to arrive, you want to plan ahead. Now, once the times when you call dispatch for a bariatric stretcher, sometimes you'll be told it's not available because obesity rates are rising in America. Obesity rates are rising all over the world. So it's the situation where the bariatric the ambulance is already busy somewhere else. That situation is increasing in probability. Then what do you do? Well, then you have to make a call. Do you wait for that ambulance to become available, or do you have to do the best you can with what you have? Does that sound like I'm telling you to risk your own well-being in order to lift this patient who's having a life-threatening medical emergency? Of course not. Of course, you should never risk your well-being. But there are times when you have to push the envelope of what is acceptable in order to do the best for your patient. Homelessness and poverty, absolutely. You probably got a patient in this situation during your rotation. It's very common. It's a continuing problem here in New York City. It's even here in Queens. There are homeless people living in the streets. How did they get there? Well, that's a sociology issue. But don't be surprised if your patient has mental health issues, they are severely malnourished, they have substance abuse problems, IV drug abuse, and then if they share dirty needles, then they end up with AIDS, HIV. Hepatitis A is a continuing problem in the homeless community. Pneumonia, TB, even TB. So situational awareness always with anybody, but especially with somebody who is undomiciled. Oh, the term used on the radio is undomiciled. Let me spell that for you. Undomiciled, without a domicile, which is the fancy word for home. So without home. That's a common term I've seen on PCRs too. So instead of saying homeless person, and so undomiciled is saying they don't have an official home address. That's what undomiciled means. Unable to obtain official home address. There. Basic needs leading to malnutrition. Without a roof over their head, they are prone to pneumonia, other diseases. They do not take usual disease prevention. They don't see a regular doctor for preventative care. Victims of domestic violence, of course, prone to accidents too. They come from impoverished families. So professionalism, compassion, you're the patient advocate as always, like that. A common thing that EMTs fall into, a common mistake or situation or mental outlook that many EMTs fall into is they meet one and they think they're all like that. I've seen some horrible things. I've heard some horrible things from my EMT partners. I didn't confront them because I had to work with them, but I didn't agree with them either. I just found a quick diplomatic way to change the topic, so at least to let my partner know that I'm not following them. I'm not on that page, but I don't want to judge them or confront them like that. What's happening is called confirmation bias, and it's a kind of bias where You overweight, you put over too much weight on the thing, on evidence out in the real world that confirms your theories of the world, and any evidence you see that is contrary to your favorite theories, you discount or ignore or pretend you didn't see it. So eventually, at the end of the day, you only remember the evidence you've seen that supports your favorite theory, and you remember nothing that might force you to rethink your favorite theory. That's confirmation bias. EMTs get into that rut all the time. But the truth is that your job is to be an advocate for all your patients, not just the worthy ones, but all patients. We always take care of patients regardless of the person's ability to pay. Hospitals do that too. That's called EMTALA. In fact, as a working EMT, you will hear this word a lot. EMTALA is the hospital, the emergency room must take care of this patient regardless of the patient's ability to pay. You probably heard that in the medical legal lecture already. Maybe you heard it but forgot it. What lecture was that? Lecture 4, chapter 4. So just to remind you that a hospital cannot get rid of a patient because they can't pay. They must stabilize, at least stabilize so that they're safe enough to discharge. Social services, they have representatives in the emergency room. They should be made aware of your patient if they have an inability to pay, difficulty paying. Okay, so there are congenital diseases and acquired diseases. Congenital diseases means they were born with it, with genital, or, well, in this case it means birth. So it could be hereditary, or it could be something that happened during birth, like anoxic brain injury. Acquired diseases means they weren't born with it, they just got it later in life. Spina bifida is a congenital disease. It's actually developed in utero, in the uterus, and what happened is the spinal cord didn't, the vertebrae, the spine bones did not close over the spinal cord, which means the spinal cord was free to grow out unconstrained by the bony tube, and then the child is born like that. Well, what do you do if this child is already like a couple of weeks old and you arrive for a different medical emergency, but now you have this patient who also has spina bifida? Same thing, as same answer as in the OBGYN lecture, which is cover with saline moistened gauze, because this is kind of like an evisceration. So saline moistened gauze, and then warm dry dressing above that, because this is a serious hypothermia, loss of heat risk. Warm dry dressing above that, cover with a warm blanket, have the caretaker transport with the caretaker, keep safe. Secure the baby on the stretcher in case the ambulance gets into a car accident. You will learn in vehicle operations that no, the mother is not allowed to hold the baby in her lap on the way to the hospital. That is actually against the rules, because if the ambulance gets into an accident and the ambulance tips or goes spinning, then that baby is going flying. VP shunt, ventricular peritoneal shunt. What happened to my mouse? Okay, here it is a tube that doctors connect from the brain to the abdomen. What's happening is hydrocephalus, hydro meaning water, cephalus in the brain. Something in the brain is generating too much cerebrospinal fluid, and so it needs to be routed out of the brain down this tube, wait, you're saying, wait, it looks like it's under the skin. Yeah, it is. They sew it under the skin all the way down to the abdomen, where it dumps into the abdomen, and then that fluid is reabsorbed into the body. Sounds like a serious potential risk of infection into the brain, and if you said that, you'd be right. So be on the lookout for signs of infection. Anywhere there are sutures, you look to see if the sutures got infected. Patients sometimes have bowel and bladder control issues. Be understanding. Have lots of towels. Extreme latex allergy, except that nothing in our ambulance has latex. I don't know of any hospital or ambulance that still buys latex gloves. Patients with paralysis, so unable to move part or their whole body, could be a result of stroke, trauma, birth defects. Hyperesthesia, so esthesia, sensation. Hyperesthesia means too much sensation. What's happening is the nerves that go from the skin up to the brain to tell sensation is overstimulated as a result of the nerve damage or brain damage. Communication challenges make sense, right? Tongue, mouth, lungs not working, so inability to make sounds as ordinary people do. Diaphragm too. Diaphragm not working, they don't breathe as for themselves, they may need to be on a ventilator. People with paralysis, they cannot go to the bathroom by themselves, they may have chronic catheters. Catheters is a tube going into the urethra for urine, into the throat for tracheostomy, into the abdomen, into the colon for feces, or into the stomach for feeding. This lady apparently has visual disability, so let's talk about that. Visual impairment. Always introduce yourself no matter what the patient is. It's always polite. You're a stranger in their house. Introduce yourself, introduce your team. Tell them everything you're going to do before you do it. It's always a good idea, no matter what the patient is. It's good to get consent or implied consent. Express consent. Visual aids help depending on the kind of visual impairment they have. Speak clearly and calmly. The patient, if they don't see you or see you well, feels vulnerable. So explain everything you're about to do as you do it. Before you do it, describe everything to them so at least they have an idea of what's going on. If they use a cane or walker, of course bring it to the hospital. These will fit. A walker can fold, so you can fit it in your ambulance. If they have a service animal, that I'm not sure. I never had a patient with a service animal. I'm not sure if you can transport them into the hospital, or you have to call for supervisor. At the very least, ask the caretaker, what do you usually do with this service animal when you need to go to the hospital? Can next of kin come and take care of the animal? So I think that was the answer. That's always been the answer. Always call next of kin or friend or neighbor to take care of watch the animal while you take them to the hospital. Never push or pull your patient. Just let them put their hand on your arm or invite them to hold your arm, and then you take a slow walk in the direction you want to go, and the patient can then comply. Of course, you have to make sure that you guide them into clear ways. Don't walk too close to a wall or a pole that they may walk into. Communicate obstacles in advance. For the hearing impaired, so they can see, but they can't hear so well. Okay, conductive versus sense. Well, yeah, this is the definition. But as EMTs, we're you're really not trained or expected to tell the difference. But anyway, if you want to know, here's the two different kinds of hearing loss. Sometimes they have hearing aids. Sometimes if they lived a life without hearing, then they don't know what a word is supposed to sound like. So they pronounce things, but then they don't realize what it sounds like. Compassion, professionalism, of course. Sometimes they don't respond because they just didn't hear you. So what you want to do is be directly in front of their face so they can see you, and then pronounce your words normally. Do not overpronounce, because they are used to reading lips as they are moving normally. If you overpronounce, then your lips are moving in an unusual way and they don't know what you're trying to say. Overpronounce meaning do not exaggerate your lip movements. Paper and pencil is a great idea. So another reason why you would want to have paper and pen or pencil around. If they are wearing a hearing aid, do not speak louder. You're going to distort the hearing aid. ASL is American Sign Language. It's not universal. Not every deaf person in America knows ASL. So don't assume it. Paper and pencil is really the best way. Only one person asks questions at a time. Don't have you and your partner standing on opposite ends of the patient and start talking at them like it's some kind of inquisition. Designate one person to be asking all the questions so they can stay focused on that one person. Reverse stethoscope is where you put the ears of your stethoscope in their ears and you talk into the diaphragm to help amplify the voice. That's only if they don't have a hearing aid like this. The main point about hearing aids is that you should not shout. Shouting will cause distortion. Do not talk louder. Just talk at a normal volume and rate. That is what the hearing aid is tuned for, designed for. Anybody with any special condition, you always want to ask why they called 911 this time. What's different today? The chronic disease has been going on for years. So that's not why they need to call 911. What's different today that they needed to go? Advanced medical device. If you walk into the patient's apartment and you see this, and you're an EMT, one of the first things you need to do after the primary is call dispatch and request paramedics. I see a tracheostomy tube. Hello, where's my mouse? I see a tracheostomy tube going to a portable ventilator, and of course a lot of IV tubing. As EMTs, you are not responsible for transporting this patient. You do not have the equipment, you do not have the training to transport this patient. This is a ALS, a paramedic patient. So get on the radio and say, dispatch, my patient is on a vent, has a tracheostomy, has 1, 2 IV pumps. I need ALS for ALS equipment and maneuvers. But until paramedics get there, what can you do? Well, airway, breathing, circulation. Airway. The airway is right here in the tube. If it's clogged, then you may have to suction. Clogged with what? Clogged with saliva, with sputum, with mucus. You may have to suction until paramedics get there. If they're not breathing, why not? Because the ventilator is not working. Then what do? Well, don't mess with the ventilator. What you do is unplug the vent tube and put your BVM right there. Take the mask off the BVM and connect the BVM tube right here to the opening of the tracheostomy. It'll fit. It's designed to fit. And then you give ventilations until paramedics arrive. Circulation, treat for shock. Recognize and treat for shock. If there's any serious bleeding, life-threatening bleeding, seal the bleed. And then finally, paramedics will arrive. They'll still need you for lift assist and to hold. You may, at the very least, have to carry some of this equipment and take it to the hospital. So that's it. What the question is, what to do if a medical device fails? Well, what was the device trying to do? If it's an airway breathing circulation assistance, then you take over that airway or breathing or circulation. So is the failure of the device life-threatening? Then you take over. You remove the device or ignore the device and just do what you got to do. Do you have the knowledge to fix the problem? With medical devices, you don't. With patients' own medical devices, you don't have the knowledge, you don't have the training, so you don't have the authority, technically. Just do your own ABC support. Since more and more patients are being treated at home for chronic conditions, they are kept in the hospital as little as possible, then more and more patients are, and with the advancing of medical technology, more and more patients are ending up home with these advanced medical devices, and then something happens and they call 911 and you're sent. Most of the time what you got to do is call for paramedics so they can help figure this out, and then together the four of you transport this patient to the hospital. So how do you know if the medical device is failing? ABCs and mental status. That's how you know. If the patient can hear you, and assume they can, then always explain what you are doing before. And of course, patient's caretaker, family, friends, whoever is there to take. I once had a patient where the other person there was their friend, was not a family member, was a friend. But the friend knew everything about this patient's medical device and how to deal with it, so we were using that friend as a next of kin resource, asking questions, asking for advice, and together we all helped this patient get onto our stretcher, into our ambulance, and transport it safely. Here's a better look at that transport ventilator. You see these numbers here? Mouse, here's a better look at this transport ventilator. You see these numbers blinking on the screen? Don't mess with it. Do not change it. Do not play with it. I don't care if you've seen other EMTs do it. I don't care if they taught you how to do it. That is way outside your scope of practice. Do not mess with it. Instead, call for paramedics. While waiting for paramedics to arrive, you can get a set of vital signs. That's something EMTs are good at. So go ahead, get those done. Get a pulse ox. See if their breathing is adequate for their needs. Are there signs of cyanosis? What's the CTC of the skin? How's their mental status? These are all the things you can do. Keep the patient warm with a blanket. Ask caregivers for help. They are a great resource. They know what's going on. They know what's broken. They know how to fix it. Sometimes you see this, and this is a CPAP, not our CPAP, not an EMT CPAP. This is a home device CPAP. The air pressure goes to the nose. It's really there for patients who are snoring so bad that they have a condition called sleep apnea. But if you're there, they're already awake, they're not going to be wearing this. CPAP is a non-invasive positive pressure. What's an invasive positive pressure? Intubation. But that's not an EMT thing. We've already talked about CPAP. Yeah, we've already talked about CPAP. Okay, tracheostomy tubes. So sometimes they have a device actually sewn into the skin and installed here. Sometimes they don't. Sometimes they just have a hole. Anyway, if they're not breathing adequately, the BVM will fit right here. You take the mask off the BVM, so with the BV, you fit right on this connector. It's an international standard fit, and you can breathe for them. A common complaint is that mucus builds up right here. So what you do is insert a French catheter, not a rigid suction catheter, but a French suction catheter, and look, and especially now, look at the way this provider is pinching on the tube. Well, first of all, you're supposed to wear gloves, but anyway, look at the way the provider is pinching on the tube. They pre-measured the tube from where to where? From the tracheostomy hole to about here, the manubrium. And in class, I will show you where the manubrium is, and you are not to insert it any deeper than that. So they inserted the catheter, same way, and then similar to your suctioning scale, you insert the catheter, well, no further than you pinched, and then you apply suction on the way out. Never apply suction on the way in. And many times your patient will breathe much better because you've cleared the mucus out of there. Don't be surprised, however, if the patient starts to turn red, if their skin starts to turn red, because what you're doing is literally tickling their trachea. Can you imagine if somebody stuck a feather down your throat? How would you like it? So they're not going to like it, but they understand that you got to do it in order for them to be able to breathe clearly again. So home ventilators, don't mess with it. Tracheostomy, BVM, if the home ventilator is not working. Sometimes they have these so this is different. Sometimes they have home oxygen. So either from an oxygen tank or it's compressed air. Anyway, they call 911 for some other reason, and you arrive and you see on a nasal cannula is connected to a machine, and you find out that they are on home oxygen, usually around 2 liters per minute. One of the first things I do is switch them out to my oxygen tank. And the main reason for that is compassion for the patient. Because these home oxygen systems, they're expensive. And even if it's covered by insurance, it's still a pain to replace. They have to go somewhere to get a new oxygen tank. It's just a pain. So as soon as convenient, what I'll do is I'll switch out, I'll just unplug their nasal cannula from this port and plug it into my oxygen tank and let them use my oxygen. That way it's convenient for the patient. And then also this way I can increase the oxygen rate up to 6 liters per minute on nasal cannula if I think the patient needs it. We already talked about home ventilators. We already talked about BVM if the ventilator is not working. How do you know the ventilator is not working? Because they're showing signs of hypoxia. You will not see this in real life. I think this picture is only to show you what this ICD, implanted cardiac defibrillator, looks like. It's a metal coin. It's a little bigger than a silver dollar and thicker too, and it's supposed to be completely under the skin and sewn shut. The skin is closed, sutured shut. But anyway, it's usually over. So why is this displayed like this? This is probably a cadaver. So somebody who donated their body to science after their death, upon their death. Anyway, this is supposed to be done under there. It's usually in the left upper quadrant. Why? Why is a implanted medical device usually in the left upper quadrant? Think about it. You know the answer. You already know the answer. Anyway, it's there. So this one is it's either, most commonly, it's either a ICD, implanted cardiac defibrillator, or a pacemaker. So the ICD delivers a shock to the heart as needed if there's ventricular fibrillation or ventricular tachycardia. A implanted pacemaker does something completely different. It maintains the pace of the heartbeat. Either way, they both need batteries. Sometimes so before the battery empties, the patient has to go to the hospital to have it replaced. So yeah, pacemaker, make sure the heart rate stays between 60 and 100 beats per minute. A ICD or automatic ICD will shock the heart when needed. Now the ICD, since it's implanted and the electrodes are like right next to the heart through thoracic surgery, the charge doesn't have to be very strong. Your AEDs, the charge has to be enough to kill a man. That's literally what it's doing, because it's placed over the skin and it has to travel that long distance across the chest. But since the electrodes here are right next to the heart, the charge does not have to be strong. You don't have to be clear. You don't have to not touch the patient. In fact, you're not going to get a warning. You're just going to see the patient go, ow, and you say, what happened? And then he says, oh, my ICD just went. So you, of course, you're not going to mess with it. But what do? Well, if there's anything sticking out of the body, you want to inspect it, verify that there's no signs of infection or leakage or drainage, and leave it alone. And that was an internal defibrillator. Some patients walk around with a defibrillator vest. This is the same as your AED. It's the same as your AED, but the patient is wearing it continuously. And this one will deliver a shock with the same power as your AED. So in order to make sure it's safe, this one will announce shock being delivered. Stay clear, shock being delivered. So when you hear that, you better let go or you're going to get shocked too. This is not a permanent solution. This is a temporary solution while the patient is waiting for their surgery appointment to have an ICD implanted. But anyway, one of these days you may get a patient like this, because after all, they've got a sick heart. Anyway, what you do is you take care of this patient. It's a good idea to call for paramedics so they can get an EKG going, because obviously this patient has a sick heart. So paramedic EKG would be a great idea. This is completely different. This is a left ventricular assist device, or LVAD. Here's a guy living his best life, even though he's got an LVAD. And the idea is this. It takes blood from the left ventricle, routes it through this propeller, this pump, and sends it into the aorta. And so it's kind of like, well, it's assist, right? It's assisting the ventricle to push blood out to the aorta, because the left ventricle is very, very sick and he needs a lot of help. This thing here is a battery to provide power, continuous power to this propeller. How will you know the patient has an LVAD? Well, he tells you. If not, you'll see this thing and this wire sticking out of his body, and you're going to wonder, hey, what's this thing? And hopefully patient next of kin or the medical alert bracelet or medical alert necklace will tell you this is an LVAD. So it's usually a temporary thing. It helps the heart pump blood throughout the body, maintain blood pressure until they get a heart. They're waiting for a heart transplant is really what's going on. But now the question comes up, what if the patient cannot tell you because they're unresponsive? What did you learn in CPR? What did you learn to do for somebody you find unresponsive? You check pulse. The problem is they may not have, the LVAD may be functioning perfectly fine and you won't feel a pulse because this thing is a propeller. It's not a pump. So when you put your finger in their neck, instead of feeling a pulse, you feel nothing because it's just this continuous flow. If you put a stethoscope here, instead of hearing lub dub, lub dub, lub dub, you hear a mechanical whir, 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 whir. It sounds like a propeller. It sounds like the screws of a submarine churning away. What are you supposed to do? Because if you feel no pulse, you've been trained to start compressions. But can you imagine if you started compressions on this thing? You may rip it apart. You may tear it apart. You may pull this wire out of the propeller and it's now disconnected. So what are you supposed to do? Well, let's see. What does New York State say? Let's go bring down the New York State protocol, NYSBLS protocol. Download it and then search for ventricular LVADs. Page 59 out of 91. What does it say? Anything? Oh, what's the previous one? Never mind. Here it is. Perform CPR only when there are no signs of flow or perfusion. The person is unresponsive, pulseless, and there's no evidence of the pump functioning. For example, no hum of the motor. So you put your stethoscope over the heart and you hear nothing, and there's no pulse. And of course, there's not responding, and then you do CPR. Didn't I just say that compressions on an LVAD may destroy it? Yes, but what are you gonna? But it may not. And now you have this dilemma: do I do nothing and let him stay dead, or do compressions and maybe it'll help? But something that you really need to know is that you have to transport this patient to the hospital that put it in. You cannot transport this patient to any old 911 receiving center. You cannot even transport this patient to the nearest cardiac center. They don't know what's going on. LVADs are not standardized yet. It's not like you can go to Home Depot, or you can't go to Walmart and buy an LVAD. They are separately constructed and installed by individual hospitals. There's no standardization between hospitals. So you have to transport to the hospital that put it in. Let's see. Don't disconnect the LVAD. Yeah, it's going to stop working. All right, so that's what New York State says. New York State says if no pulse and you don't hear the machine in the chest, then start compressions. Let's see what New York State says. Okay, this is something you're not used to seeing, right? New York REMSCO. I've been telling you early in this semester to not look here. Do not look here because you're studying for a New York State exam, not for a New York City exam. In fact, there's no such thing as a New York City EMT exam. This is more of a paramedic thing. But anyway, we want to see, we're just curious to see what New York City says about LVADs. Good grief. Let's, to save time, let's go back up to other specialty care. Let's go backwards. Here it is. Let's see. This is page 173 of 176. Here, perform CPR only when there's no signs of flow perfusion. Oh, so this is exactly the same as the state says. This is the same information. They just copied and pasted what the state says. Okay. 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 Let's go to okay, and that's what New York State says. All right, so they both, New York State and New York City, say go ahead and do CPR, but only if you don't hear a hum and no pulse, no response. Okay. CVC, or central venous catheter, you know what, let's jump to the chase. My throat is getting a little sore. Just don't mess with it. Do not use it. Don't mess with it. Just document if the dressing is clean or leaking. This dressing here, that's it. Just do not mess with it. NG tubes, gastrostomy tubes. So this is how food is put into the stomach. Why? For various medical reasons. But for some reason, it's not safe to allow the patient to swallow food the normal way. So they got an NG tube, or a feeding tube, or a gastrostomy tube. So again, do not mess with it. Don't play with it. There's no reason why you need to put something into the stomach or take something out. So don't mess with it. Just document what you see. Inspect with your eyes. If it's covered by gauze and tape, leave it alone. Just write down if you see if it's clean, in place and clean, or if it's leaking or stained. Yeah, just document. Is the dressing in place? Is it clean, or is it leaking? Sometimes the patient may call 911 complaining of abdominal pain, that it's bleeding, and then just write down what you saw. Again, write down what you saw. If it is leaking, you put more gauze there, tape it in place, and transport. When somebody with any kind of gastric issues, stomach issues, you want to transport in position of comfort, semi-Fowlers, or about 45-30 degrees, because otherwise if you lay them supine, then the stomach contents may dribble out into their throat. So that's a little, that's risking aspiration and of course discomfort. So transport position of comfort or elevated. Here, why is the VP here again? This belongs back up there. Here's another picture of the ventriculoperitoneal shunt. And it's the tube is sutured under the skin all the way from the head all the way down to the abdomen. So what do? You check the dressings for that it's clean, no leaks, no discolorations. That's it. Don't mess with it. Do a neurologic exam, which means circulation, motor sensory, hands and feet. Assess pain in the head, neck, or spine. Mental status check. That's the neurologic exam. If it's a child or baby with VP shunts, then check if they have bulging fontanelles, which is intracranial pressure. Be ready in case there's a seizure. Many of your patients, especially nursing home patients, will have urinary catheters. So there's a tube going up their urethra, and then urine is coming out and going into this bag. So a couple of things really. First of all, before you transport, of course you have to unhook the bag from the nursing home bed before you move the patient to your stretcher, right? Otherwise you will yank the tube out. But before you lift this bag up to patient level, you have to clamp the tube closed. Otherwise, when you raise the bag higher than the bladder, urine will flow backwards into the bladder. So to prevent that from happening, find the clamp it's somewhere. The clamp is along here somewhere. Clamp it closed so that there's no backflow. And then rest the bag, usually between the patient's legs so it doesn't fall out. And then transfer the patient to your stretcher. Never let the bag touch the floor. That's just dirty. You can document what you see in the bag. You know, it's supposed to be clear yellow like or apple juice. If it's cloudy like miso soup, it's pyuria, it's pus. It's dissolved pus in the urine because of an infection. If there's blood, then that's hematuria, you know, etc. Just describe what you see. Before you unhook it, maybe if you know how to do it, you can read the level here. I can't tell what it's saying. It's all blurry. But, you know, just read what line it's at, you know, just to be helpful. Here's another guy with a urinary catheter. So yes, they can be mobile. They just have to be very careful where they walk. Ostomy, and it's usually not ostomy by itself. Like if it's connected, if it's a hole going to the colon, it's a colostomy. If it's a hole going into the ileum, which is the end of the small intestine before it joins the large intestine, it's an ileostomy. So ostomy is like a suffix, and it means a hole through. It's a stable hole through, and the patient may have it for various reasons. They need access to that, or they need to that organ, or they need to let it empty out this way. So a common reason for a colostomy bag is because something is going on medically with the rectum and anus, so it's not safe to allow them to go number 2 in the bathroom the usual way. So instead, they get an ostomy. Sometimes it's long term, and here's a lady living a full life with a colostomy. Looks like a colostomy. So what do you do? Again, document whether it's in place, secure. If there's dressing, is it clean or is there leaking? With a colostomy, you can smell if it's leaking. You can smell if it's not properly clean. Don't clean it for them, but document what you see. The reason why I keep saying document is so that you can state for the record how it was when you had the patient. That way later, if everything goes to hell and then the family of the patient tries to sue you saying you caused this, and your only defense is what you wrote on the PCR, and on the PCR you wrote device, whatever the device was, noted, in position, and then use anatomic landmarks, dressings in place, clean, no leakage, no discharge. There, that's your words on paper, shown to the jury in a court of law, and that is your only defense. So that's why you document to protect yourself. It's also useful for the doctor to know that everything was fine and clean during EMS transport. Then this mess that they have in front of them must have happened after the patient got to the hospital. Signs of infection, no matter what the body part is redness, warmth, hot, and then tenderness. So that's signs of infection, and of course fever. Urostomy is when the hole is to the bladder. Uro for urine. Your first job as an EMT when you graduate out of here is likely to be with a private transport company. unless you know somebody who knows somebody who can get you a 911 job. But the rest of you chumps, you're going to end up in a private transport agency. But that's not a bad thing. It's just, it's an entry level job, and it's hard to get 911 jobs without experience. But how do you get experience without a job, right? So this is how you start out as a private transport EMT, and there the most common call is a dialysis transport. You show up at the patient's house or a nursing home, you pick up the patient, you do your assessment, you put him in your ambulance, you go to the dialysis center, you drop them off, you sign off with the receiving nurse at the dialysis center, and then you say, "Nice to meet you, have a nice day." And then you or somebody else picks them up a few hours later and takes them home. And if that doesn't sound very exciting, the answer is it's not. But that's where the money is, and your private ambulance company is trying to make a profit, and so it picks up these dialysis transports all the time. These are scheduled transports, these are not 911 emergencies, and you're there after like a few months of doing this day in and day out, maybe several times per shift. You're starting to wonder, like, is this why I became an EMT, just to do dialysis transports? Well, that's your first job, right? The exciting stuff, the dramatic stuff will happen later, after you go on to, you build up enough experience here in your first job, and then you get a 911 job later, and now you can be the hero you always wanted to be. But for now, do a good job, do good work, never cause an issue with your supervisor, don't cause problems at your job, and then you can eventually accumulate a good letter of recommendation to help you get another job. And then after 6 months to a year of this, you finally get a 911 spot somewhere, and you leave. You leave town, you jump ship, you go to that other job. It pays better, it's more exciting. And guess what you just did? You left a hole in that company so that another brand new EMT can fill it. And that is the cycle of life, the circle of life in EMS careers. While I've been saying that, you've been probably looking at this arm and seeing this bump on the arm. That is a dialysis shunt, also called a well, it's like many names, but anyway, at the dialysis center, this is where the techs will connect the tubing so that blood can be pumped out of them, sent through the filter machine, and then pumped back into them through another tube. This is very fragile. Sometimes it's on the forearm, sometimes it's put up in the upper arm, exactly where you would have put a blood pressure cuff. So what you need to remember, fistula, that was the word I was looking for. Sometimes it's called a fistula, sometimes it's called a shunt. It's the exact place where you would put a blood pressure cuff, but because it's so fragile, the act of getting a blood pressure will destroy it. So never ever take blood pressure on the arm with the shunt, fistula or graft, sometimes they call it. Never ever do that, because once you do, now this patient has to go back into the operating room to get a new one put in. Very inconvenient for this patient. So the patient has been trained to not let any EMT near that arm. But the problem now is, what if the patient is altered mental status or unresponsive? Then what are you supposed to do? Well, you are supposed to take a good look at that arm before you put the cuff on, to see if there's any reason why you should not put a cuff on that arm. And this is why you must get blood pressure on bare skin. You cannot take anybody's blood pressure through clothing. You may think, I've been to the nurse, I've been to the doctor, they always took blood pressure on my sleeve, they never had me roll up my arm. Do you know why? Because you were there as a scheduled visit. From the waiting room to the receptionist, to being greeted by the medical assistant, everybody could confirm that you are alert and oriented and you don't have a dialysis shunt. That's why that nurse put a cuff on you through your sleeve. But when you are responding to an emergency, you don't know if this patient is a dialysis patient or not. You must look at their bare skin to confirm there's nothing there on that arm that would prevent you from using the blood pressure cuff on that arm. Never, as an EMT, never, ever take blood pressure over somebody's clothing. Always remove the clothing. Roll up the sleeve or cut open the sleeve if you have to get the blood pressure. What happens if it's bleeding? Pressure. Now you have to save their life. So now you have to put a pressure dressing. What if it's bleeding so much that they may bleed to death? Tourniquet. Didn't I just say that it'll destroy the shunt? Yeah, but they're going to die if you don't put the tourniquet. So it's better to put a tourniquet and make them go back into surgery later for a new shunt than to save the arm but lose the patient. Besides, if they are bleeding that much from the arm, from trauma, then it probably destroyed the shunt anyway. Central IV catheters like a PICC line or any of these, again, same as the triple lumen catheter. Where was that? Same as the central line. Same as that. This one, the CVC. Don't mess with it. Just inspect it. Make sure the dressing is clean. It's not leaking, and then leave it alone. We already talked about hearing and sight. Speech, for speech impairment, paper and pen. Same, no. If they have physical difficulty getting on your chair or stretcher, help them. Abuse and neglect. So, according to your student manual, you have to get the mandated reporter certification. And that's where you learn all about this and how to recognize abuse and neglect. Let me jump to what you actually put on your PC, what you actually do after or before you call the mandated reporter hotline. First of all, do not confront the caretaker. They may react violently, defensively and violently, that you are a threat to their well-being. If you have suspicions, then you keep it to yourself and write it down, and then later call the mandated reporter hotline. Now, on the PCR, you write exactly what you see. No opinions. No opinions. Only your objective findings. I found this laceration this long at this anatomic landmark. I found this burn, this sign of burn injury, second-degree burn injury, covering this much total body surface area at this anatomic landmark. Only write that. The most you're allowed to say on paper is multiple injuries in various stages of healing. That is like code for abuse. The caretaker's lawyer cannot sue you for saying this. I mean, they cannot accuse you of libel for saying this. because that's exactly what you saw. It could be totally innocent, but everybody who reads it knows what you secretly meant, that this is a sign of abuse. And the reason why is anybody can have a bad day. They can roll down a hill covered in cactus. Anybody can have a bad day. But they have multiple injuries in various stages of healing. Means they had an injury on one day, and then a different injury on another day, and a different injury on another day, and a different injury on another day. What the hell is going on? Maybe they're just accident prone. Maybe it's a difficult environment. Maybe they were lost in a cactus field for several days in a row. Or maybe they are victims of abuse. So by saying multiple injuries in various stages of healing, let me put that in quotes, and then let me put maybe italicize this. So what, left out the G. So by writing this, you're kind of cluing in to whoever's reading that you should think about abuse. So you document exactly what you see, no opinions. Don't say, I think this kid's being abused. That will get you convicted of libel. But you just document exactly what you see, write multiple injuries in various stages of healing, and then call the mandated reporter hotline, and then at the hospital find the attending physician, ER physician, and say, hey doc, I need to talk to you, and quietly, discreetly tell them what you're thinking. And your job, your professional responsibilities will be complete. Last component of this lecture. It's been a long lecture. Thank you for listening, staying with me. I hope you've been listening to this at an accelerated playback speed. I know I talk slow. Anyway, last part, terminal illness. You may get a patient who does not want to be cured or does not expect to be cured. They just want to be respected and have their immediate physical needs taken care of. They just want to be, they just want the pain to go away while they wait for end of life. And that is called palliative care. Palliative care is to reduce suffering, not to find the cure. Because the illness is terminal, and the doctors have all agreed that trying to cure this situation is not worth it. Hospice is a place for palliative care. This patient likely has a DNR, but DNR does not mean do not treat. DNR just means do not resuscitate. If the patient needs oxygen, give them oxygen. If they're in pain, well, EMTs don't carry pain meds, but do what you can to reduce the pain, and then consider calling paramedics to give pain meds. If the patient is bleeding, stop the bleeding. DNR does not mean do not treat. You still have to treat. But then they are going to have an advanced directive. You just follow the advanced directive. All right, there's still a few slides to go, but it's summarizing what I just said. I'll let you read these on your own. Download the slides. I'll put these slides up there, the usual place, and then you read them on your own. But now you've heard enough from me to answer these questions on your next quizzes and exams. So good luck with that, and you will see me on Monday.